In this next segment, we're going to look at a variety of different kinds of cardiovascular issues of abnormalities, atherosclerosis, and cardiac arrhythmias. So the first part of this is atherosclerosis. This is a name for a version, a type of hardening of the arteries. This is a really important illness because it contributes to about 50% of the deaths that occur from heart attacks and strokes. So you will see this as something very commonly encountered when seeing patients with cardiovascular disease. What happens is you have plaques that build up and in the layers of the blood vessel walls. And these plaques, as you can see here and in this lower cartoon thing, as these plaques build up, then this reduces the diameter of the inside of the blood vessel and reduces blood flow. Another problem is eventually this can result then as a site for a blood clot to form. A thrombus is another name for a blood clot. And as you can see, here's one that's stuck onto the spot, and now this occludes that blood vessel even further. Another problem, of course, is that these blood clots can break off, and if they break off, they can then clog other blood vessels, coronary arteries, and cause a heart attack, or travel up through the carotid arteries into the brain and cause a stroke. So these plaques form in large part because of some kind of damage, some sort of insult to the endothelium of the blood vessel. And those insults can come from a variety of different kinds of sources. Cigarette smoking, for example, high blood pressure, diabetes, elevated cholesterol, either genetically or from your diet. So let's look at elevated cholesterol a little bit and talk about the different types of cholesterol. So when you go to your physician for your yearly physical, you'll get a blood test and they will measure your cholesterol. And in fact, actually, they're not really measuring just your cholesterol. They're measuring these things called lipoproteins. And you can see this is what they look like. It's not just cholesterol. It includes phospholipids, cholesterol esters, triglycerides, polypeptides called apolipoproteins, some free cholesterol molecules as well. But it's a complex, and so hence they're called lipoproteins. And they come in a couple different flavors. There are low-density lipoproteins and there are high-density lipoproteins. And actually, you can divide them into further categories than that. But for the purpose of this course, those two definitions will suffice. So people who have high amounts of LDLs, the bad cholesterol, this can come from either consuming a lot of cholesterol in things like butter or cheese, animal fats, for example, or they can produce it themselves genetically. The liver produces this. And so some people can eat a huge amount of cholesterol and their blood cholesterol always remains low. And others can eat almost nothing and their blood cholesterol is elevated because of their genetic basis for that. High levels, as I mentioned, then is associated with an increased development of atherosclerosis and the formation of those plaques. High-density lipoproteins are the other type. This is the good cholesterol. And they're good cholesterol because, well, they carry cholesterol away from the arteries, bring that to the liver, and the liver then breaks that down. It takes the cholesterol away from these macrophages that are the ones that develop help to increase the development of plaques. These are referred to as foam cells. There are drugs now that have been around for quite some time that can be fairly effective at lowering your cholesterol. Statin drugs like Lipitor, for example, is one of the common ones. There are a variety of other ones that are out there as well, are pretty effective at reducing LDLs. And then there are other drugs out there that are fibrates. Niacin is a type of vitamin B. And these have some evidence of helping to increase LDLs and, HDLs. And as a consequence, then these are beneficial. So it's not just your total cholesterol, which you'd like to have below 200, but it's the ratio. And so even if your overall cholesterol is a little bit elevated, if the ratio is good, that is, you have a high amount of HDLs relative to LDLs, this can be beneficial. You can raise your HDLs a little bit with a lot of exercise and weight loss. So there are ways to improve your panel by increasing the ratio of HDL to LDL with changes in lifestyle. There's also evidence to suggest that a major component of atherosclerosis is inflammation. And some evidence to suggest now that measures inflammation, for example, this protein called C-reactive protein that you can measure in the blood, might give a better predictor of whether someone is going to have atherosclerosis than just simply measuring the LDL levels. Another contribution to atherosclerosis is that when the cells of the blood vessels engulf these LDLs, they oxidize those LDLs, and that oxidized LDLs are even more dangerous and cause additional damage to the endothelium. And so, as a consequence of this pathway, this oxidation pathway, there's evidence to suggest that antioxidants may be beneficial as well. These include things like vitamin C and vitamin E. And the evidence on that so far isn't wonderful, but this is now a hot topic of research, and hopefully people will be able to develop another mechanism of treating these diseases. One of the problems with atherosclerosis is it can lead to what's called ischemic heart disease. Ischemia simply means depriving cells of oxygen. So there's inadequate blood flow, and atherosclerosis and occlusion of the diameter of those blood vessels is the primary reason that happens. So the cells downstream of that occlusion just don't get enough oxygen. This results then in the production of lactic acid. If you remember in glycolysis, if there's oxygen around, pyruvate is able to enter into the mitochondria and you go through the citric acid cycle. But if there isn't any oxygen, it takes a different pathway, and that is it becomes lactic acid. And so lactic acid can cause chest pain. This is called angina pectoris, or sometimes just angina. In addition, though, sometimes you can have pain in other places and not heart pain or chest pain. We discussed this before about referred pain. So sometimes this can manifest as pain in the left arm, for example. If ischemia it persists, eventually the cells can't survive. They die, and this is called necrosis. And unfortunately, necrotic cells do not get replaced. And they're also not electrically active, and they don't contract. And so as a consequence, then that part of the heart doesn't contribute to adequate pumping. This is referred to as a heart attack in layman's term, or a myocardial infarction, or MI are the technical terms for that. So when somebody is suffering from chest pain, one of the treatments that has been around for many, many years, decades, is these little tablets that are called nitroglycerin. They're put underneath the tongue. And the way this works is that they are nitric oxide donors. And as we've mentioned before, nitric oxide is a vasodilator, so it increases blood flow. Also, as mentioned before, the treatment for erectile dysfunction, like Viagra, for example, or Cialis, for example, you'll see on those advertisements warnings saying, if you take nitrates for chest pain, don't take this drug. And the reason for that is that these drugs for erectile dysfunction, also increase the amount of nitric oxide that's around. So if you add that onto taking nitroglycerin for chest pain, you can get a dangerous drop in blood pressure because you'll overdilate on the blood vessels. As I mentioned before, these myocardial cells, if they undergo necrosis and die off, they don't get replaced. There is some stem cell therapy that's being worked on. We're trying to come up with ways of taking stem cells from bone marrow and being able to generate those into new heart cells. And there's some promising progress being made on that research, but it's not yet an effective treatment. But they don't divide in the heart, and so once they die, they've just become unfunctional scar tissue. Also, another unfortunate consequence is if you open up the blood vessels and you get some reperfusion of blood to those areas, this can result in something called a reperfusion injury. And this is due to an increased inflammation and some oxidative free radicals that can cause damage then to some neighboring cells and can increase the size of the infarct, increase the part of the tissue that's been damaged. This can happen not only in the heart with an MI, but this can also happen as a consequence of a blockage of blood flow that happens with a stroke. So we can look for people having ischemia by, well, those 12 lead EKGs we discussed before. And that is, you get all these different electrical views through the heart, and by looking at the different patterns of activity on those EKG leads, you can see abnormalities indicating not only where maybe in the heart that electrical activity is not normal, but even the size and the significance of the infarct. A common abnormal reading on this EKG or trace on the EKG is a change in this ST segment. You can get ST depression or you can even get ST elevation, but this is a common way of looking for evidence of ischemia. In addition to that, they'll do a blood test and they'll be looking for a variety of proteins that are elevated in the blood. Some of these are related to ones that are muscle proteins that are involved either in metabolism or other aspects of muscle function. So creatinine phosphokinase can be elevated, lactate dehydrogenase can be elevated, and then the troponins that are involved in muscle contraction, these can be elevated as well. Here's the numbers on when you see these elevations. You need not memorize those numbers. I just want you to let you know that these are a little bit of indications about when an MI might have occurred. Speaking then of EKGs, let's look at arrhythmias and abnormal heart rates and rhythms. And so a couple of terms you need to know. One is bradycardia. This is when the heart rate is abnormally low, below 60 beats a minute, or tachycardia when the heart rate is abnormally fast, above 60 beats a minute. Now, well-trained athletes can have resting heart rates a little below 60 beats a minute, but it's not very typical in normal individuals. And normal individuals should not have resting heart rates near 100 beats a minute at rest. Of course, it can go way above 100 beats a minute with exercise. So abnormal tachycardia, this 100 beats a minute, can occur for a variety of reasons. Drug use is a common one. So drugs of abuse like cocaine or methamphetamine, anything that activates the sympathetic nervous system is going to dramatically increase heart rate. Other forms of increasing the heart rate can come from ectopic pacemakers. Again, these are parts of the heart that are acting as pacemakers that depolarize at a rate faster than the normal rate, the normal sinus rhythm that is being driven by the SA node. So ventricular tachycardia, this occurs then when pacemakers of the ventricle then contract out of sync with the atrium. So they're running at their own rate and they're running faster than they should. This can then progress to something called ventricular fibrillation or VFib. And at this point, it's no longer effectively pumping and this can cause sudden death. So flutter is, tachycardia is over 100, flutter is 100 to 300, and you're still getting some coordinated contractions, but if it then converts to fibrillation here, now the cells are just sort of jiggling around, but you're not getting any coordinated efficient pumping. So you could also have atrial fibrillation. This is not uncommon, but it's not as deadly. So this can progress from a fast atrial contraction from atrial flutter. But again, what's happening is that the atria are just sort of jiggling around and not contracting in any sort of coordinated sort of way. As a consequence to the AV node, that is that electrical pathway from the atria to the ventricles, can't keep up with this. And so some of that electrical activity may get through, but others do not. This is not immediately life-threatening because, as I mentioned to you before, atrial systole squirts just a last little bit of blood into the ventricles to top off that end diastolic volume in the ventricles. It's only about 15–20% or so. So cardiac output's not reduced by very much, typically in atrial fibrillation. People don't feel very good with this. They often feel weak and they feel a little bit funny in their chest as a consequence of this. But a potentially more significant issue with this is if the blood is jiggling around and not undergoing smooth laminar flow, it wants to clot. And so you can develop blood clots, thrombi, in the atrium. And the problem is that those then clots can be passed on to the coronary arteries and cause a heart attack, or travel up through the carotid arteries into the brain and cause a stroke. So people who are suffering from atrial fibrillation, or AFib is another way that's described, are often on some kind of clot busting sort of drug, things like warfarin or Coumadin kinds of drugs. There are others as well, but those are common ones. Ventricular fibrillation, as we mentioned, here, again, the heart cells are just sort of jiggling around. Their individual ones are contracting, but they're contracting in a very uncoordinated sort of way. So the ventricles really can't pump any blood in any effective way. So these people need immediate CPR, chest compressions, to get that blood to be able to be pumped, or they need to be converted with electrical defibrillation to set that heart rhythm. What happens is with that defibrillator, is they're taking all the cells that are out of sync with each other, electrically out of sync. Some are in systole, some are in diastole, some are refractory, and some are not. And you shock them so you bring them all into a refractory state, and then that hopefully resets the rhythm and it all becomes coordinated again. So this jiggling around of this electrical activity in the ventricles is sometimes referred to as circus rhythms. And that is, some cells in the heart are electrically active and in systole, and others are in diastole, and then they're passing them on to neighboring cells. And so some are refractory and some are not. And as a consequence, the heart just sort of jiggles, but it doesn't really pump any blood. So you can go from tachycardia to flutter to fibrillation, and to then eventually to something called asystole, where you have a flatline ECG or a flatline EKG, and this would result in sudden death. Now, another abnormality that you may see, and it's not real uncommon, is something called AV node block. Again, the AV node, the atrioventricular node, is that electrical conduction pathway between the atria and the ventricles. And if you remember, there's a little bit of delay there. The idea is to allow the atria to finish the atrial systole phase before the ventricles exit the ventricular diastole and start their own systole to top that last little bit of blood off. So, but damage to the node then can cause some characteristic changes in the ECG. That is, that the interval between the end of the P wave, the wave that is the atrial contraction, and the beginning of that QRS complex that reflects ventricular systole, that little delay there is longer than normal. So it comes in several different flavors: first degree, second degree, and third degree. In first degree, it's simply longer than it should be, more than 200 milliseconds. But every P wave results in a QRS complex. Every P wave does get transmitted to the ventricles via the AV nodes. Second degree block, yeah, the delay is too long, and some P waves simply don't make it there. So they have some P waves resulting in a QRS complex, but you'll have other P waves that nothing happens in the ventricles. Third degree block, there's no relationship at all. The ventricles the atria are contracting all on their own in their own sinus rhythm, and the ventricles aren't picking up any of that because the AV node is blocked and it isn't passing any of that electrical activity. But the ventricles will still contract because the Purkinje fibers will then act as ectopic pacemakers. However, their rate of rhythm is considerably slower than the SA nodes. So the heart rate drops down to as low as 20 to 40 beats a minute. And this can be deadly. This is an emergency situation. Typically, people are sent to the ER very quickly, and often they're put in a pacemaker, an external pacemaker that will then stimulate this to get that normal rhythm back. So here's EKG examples, strips of this, the way this looks. And actually, I wish they would just draw this out instead of using real, actual examples of this, because it's a little hard to see. But here in first degree block, it's not all that obvious, but there's a greater distance than there should be, more than 200 milliseconds between the P wave and this QRS complex. That is, the P wave, the atrial electrical activity, and then the transmission via the AV node to the ventricles and generating this QRS complex. In second degree block, not every P wave makes it through. So here's a P wave, and oops, no QRS complex at all. Here's another one with no QRS complex. So you end up with more P waves than you end up with QRS complexes. Some P waves are connected to the QRSs, but others are not. And then in third degree block, there's no relationship at all. P waves are going all by themselves, and none of those are making it through. But the ventricles are still generating a QRS complex because the Purkinje fibers are taking over as ectopic pacemakers and generating their own rhythm. But that rhythm is really dangerously low, I can say only 20 to 40 beats per minute. And typically these people are very quickly have a pacemaker installed, which then will generate a new normal rhythm.